So the studies on the outcomes of Ruthenium 106 plaque brachytherapy in ocular surface squamous neoplasia with scleral invasion. OSSN is more commonly known as ocular surface squamous neoplasia. No financial disclosure. So OSS can extend horizontally into the corneal epithelium and stroma, and a little more uncommonly vertically into the sclera. Any suboptimal management in the early stage of OSSN, either due to incorrect histopathological diagnosis regarding base and margin involvement, or due to inadequate treatment despite the correct histopathological diagnosis, can lead to progression of the lesion and multiple recurrences. Any scleral invasion can progress to involve intraocularly or into the orbital tissue that can lead to, unfortunately, enucleation and exenteration. So the purpose of this study is to investigate the safety and efficacy of Ruthenium 106 plaque brachytherapy in the management of OSSN with scleral invasion. This is a retrospective interventional case series from a tertiary eye care center managed over a period of 5 years of patients presenting with primary or recurrent OSSN. So almost all patients underwent conjunctival wide excisional biopsy with 4 mm wide margin, followed by alcohol keratoepithelectomy for corneal involvement, followed by lamella sclerectomy for the scleral base, and cryotherapy to the resected conjunctival edges. This sample was then submitted to the histopathology for assessment of the scleral base and the conjunctival margin, and all those patients who had positive scleral base underwent further Ruthenium 106 plaque brachytherapy at a dose of 5000 centigrade. Results: the mean age of this of the patients in this series was 49, and majority were males, and only 2 patients were positive for HIV. The visual acuity was greater than 20/40 in 67% of the patients. About 95% of the patient had tumor location in the limbal area, 95% had in the nasal or temporal bulbar area, and 88% were nodular in morphology. The preoperative mean tumor basal diameter was 9.3 mm. The mean tumor thickness was 3.1 mm. 93% of the patient had corneal involvement, and the same number had about clinical scleral fixity. So on histopathology, all the 42 patients showed scleral base positivity, obviously because this was our study group, and only one of the patients of these 42 had margin positivity. So our results with the Ruthenium 106 plaque brachytherapy was excellent, with 100% tumor regression, as you can see in this patients and the following photographs. The surgery-related complication was 0, and radiation-related complication were 2, and that was just recurrent corneal epithelium defect, which was managed conservatively. Tumor recurrence was noted only in 2 patients, but this was at a site remote from the original tumor site, which was again treated with excisional biopsy, and since again scleral base was positive, they were retreated with plaque radiation. The mean duration follow-up was 37 months, and during this time frame, there was no patients underwent enucleation, there was no exenteration, lymph node metastasis was not seen, and no patient had systemic metastasis. Visual acuity of greater than 20/40 was maintained in 24% patients, and only 1 patient had reduction in visual acuity, and this was due to recurrent corneal epithelial erosion. So what does our result add to the existing literature? Most of the earliest reports of use of plaque brachytherapy in OSSN was using strontium 90, and the ones that reported use of Ruthenium 106 plaque brachytherapy in OSSN was in the form of case reports of 1 or 2 patients, and there was no clear indication as to when exactly the plaque brachytherapy was to be used. In this case series by Shields et al. From Wilza Institute, they used iodine 125 plaque radiation, and this case series was only of 15 patients, and because of the gamma radiation of iodine plaque brachytherapy, most patients ended up with a multitude of complications including cataract, iris, telangiectasia, corneal epithelial defect, and corneal edema and glaucoma. Further, 4 patients underwent enucleation or exenteration. In comparison, our results have much better. In our case series, we used Ruthenium 106 plaque brachytherapy. This was the first series from Asia, the largest series worldwide, and the longest with longest follow-up duration time. There were minimal complications, And our paper showed that this plaque brachytherapy was to be used only as an adjuvant therapy and not as primary brachytherapy, and also that histopathology is an important diagnostic tool. So in conclusion, histopathology guided use of ruthenium plaque brachytherapy is a safe and an effective adjuvant therapy in the management of scleral invasion of OSSN. Our study recommends that the primary management for all patients of OSSN be wide excision biopsy with lamella sclerectomy. An expert opinion is to be sought from an ocular pathologist. If the scleral base is negative for tumor cells, nothing to be done but to observe the patient periodically. But if the scleral base is positive for tumor cells, these patients definitely require an adjuvant treatment in the form of surface plaque application. Thank you.
In your series